Again, my name is Albert Kim. I'm a neurosurgeon scientist at Washington University. I do predominantly brain tumors, and I'm going to talk on updates on the surgical management of gliomas and brain metastases. Now, this is a case-based thing. I want it to be as interactive as possible, so please feel free to interrupt with questions, or you can write in questions, and it'd be nice if it could be a back and forth as we go through these cases. So, disclaimer from Monteris. These are my disclosures. And we'll start with the first case. So this is a 25-year-old right-handed gentleman who underwent surgery for tumor resection in March of 2017, about 4 years ago now, and was found to have an IDH1 mutant anaplastic astrocytoma, so grade 3, with the ATRX TP53 mutations and a low tumor mutation burden. And then he came to our institution shortly thereafter and was reevaluated. We had our neuropathologist look at that pathology again, and it was upgraded to IDH1 mutant grade 4 astrocytoma. So as most of you know now, IDH1 glioblastoma has been renamed essentially grade 4 astrocytoma because it's a sort of a parallel entity in a different lineage from the IDH1 wild type tumors. So he finished concurrent temozolomide and radiation therapy a little later that year, June 2017, and then he then went on to get temozolomide for a total of 12 cycles. And on physical examination, he was intact. And so when I saw him, this was what he showed me in terms of his original surgeries. You can see on the left the T1 with contrast, on the right T2 axials, and what you'll see is a multifocal lesion here, one in the right frontal area, left frontal area, and one in the left temporal area here. And on the T2, you'd see the T2 bright areas on the left here. And he underwent surgery at an outside hospital, like I said, and he got a resection of these areas both in the left frontal area and in the posterior temporal area, as you can see here. And then subsequently, I think he was doing quite well again after the cycles of temozolomide, and then it was interval imaging. And then he came to see me because on interval imaging, there was a new area of an enhancement here in the left temporal lobe. Okay, and that corresponds to this area that's T2 bright here. So at our institution, we do advanced imaging, and that for us includes not only things like corticospinal tract, arcuate fasciculus, DTI, but also resting state MRI. We've been doing this because of Eric Luthart's work here from early on, and so we get resting state as well as the DTI tracks on everybody. And that was especially helpful here because, you know, that lesion is sort of really in the vicinity of Wernicke's area as well as the arcuate fasciculus. So we had that imaging, and then we presented him in tumor board, and what we decided at that point was ablation of biopsy first, and then in the same sitting, doing a laser ablation of that enhancing area. And what we did was we have a trial with actually laser and checkpoint inhibitor, but this family and the patient were adamant about receiving neoadjuvant checkpoint inhibitor because of the work coming out by Tim Clohessy and Linda Liao, suggesting that neoadjuvant PD-1 antibody plus craniotomy may have a signal versus PD-1 antibody alone. And so we, as a group, we didn't really have a problem with that, although he wouldn't be on study. So we decided we would give him neoadjuvant PD-1 antibody and then do the biopsy and LITT. We typically use intraoperative MRI. I know a lot of places are doing this by placing the mini bolt and then the laser probe in the OR and then going to diagnostic imaging. And then, we've been transitioning to the laser robot. We used to use a Stealth Vertec device, but I think the ROSA robot, it certainly has improved stability compared to some other platforms, although I think Medtronic has another setup now that allows more stability for something like that. And the cool thing about this is that we could actually discharge in the same day, and this is something that's changed during the pandemic, I have to say. Before the pandemic, we were typically having these people leave post-op day 1 after the post-operative MRI, But with the pandemic, there's real urgency about not having people in inpatient beds, and so Dr. Luthard and I both started discharging people the same day. I would say, as I look back, from March on, for instance, I would say about 50% of the people we've been able to get out the same day, and so that's been a real advantage. So the treatment fields look like this. So this was just a temporal approach, and with the head turned to the right, and basically we biopsied the area, and then we placed diffusion tip probe here, and then you can see the yellow TDT lines here and the blue TDT lines here. For this kind of case, I would want to cover the entirety of the enhancing lesion with the blue TDT lines. And here is, I think, a video of this when I play that. And for those of you who haven't seen this, for instance, these will be your sort of orthogonal views. You can see the probe here on the bottom. These will be orthogonal to that probe, down the barrel of that probe. And what you can see is that the yellow, which would be sort of the dose that I would use for radiation necrosis, we'll talk about that later. And then you see the blue TDT lines, which would be the sort of the tumor kill dose that we would typically use to cover a lesion. All right. And then when we essentially covered the entirety of the enhancing lesion, we stopped. So and I just go forward here. And so if we do the MRIs immediately post-op, very typically, if we're not doing the intraoperative MRI, someone might have to wait like a day, day and a half. And so what I'm doing now is doing a post-operative CT with and without contrast, and then getting post-op imaging through MRI on a later date. Typically be something like a month or two post-op. And you can see here that area that was T2 bright, that was sort of wedge-shaped preoperatively, is now this circular shape. And here is T1 with contrast axial image. You see the typical eggshell contrast here that encompasses the enhancement. And so we're continuing for this guy. We're continuing the PD-1 antibody after the neoadjuvant dose and after the laser. Does anyone have questions about that case at all? I think one thing to really highlight is that the laser, it certainly ablates tumor cells, kills tumor cells, and the minimally invasive aspect, same day discharge is great. But I think another really interesting aspect, a really exciting aspect of the LITT is that you can incorporate this into potential clinical trials on the basis of a few different ideas that we've been thinking about. One being this idea that the blood-brain barrier is open for the duration of about a few to several weeks, somewhere in the order of 4 weeks in both human studies and animal studies that came out of my lab, for instance, that may enable novel delivery of drugs that otherwise would never make it through. And then the other idea, and really the idea that's baked into this checkpoint inhibitor with the LITT trial, is that the LITT may provide a danger signal, number one, and may stimulate the immune environment, is one hypothesis. And the other is that whereas in craniotomies and resection, you're taking out the antigens, here you're essentially baking the tumor cells and leaving the antigens in. And so perhaps that has a different effect on the immune environment.
Can you comment on nuances of placing bolt in bone flap and tangential, not perpendicular to the flap as it appeared to be in that first case?
Yeah, that's a great question. So I think, generally speaking, I haven't had that many problems going through the bone flap, I have to say. So there are a few considerations. One is obviously you have to avoid the hardware. And generally speaking, we can do that. I haven't had any issues with the stability of the bone itself. Actually, the biggest issue has been the dura, because typically I do duroplasty on top of the primary dura closure, and what you really have to punch through that multiple layer duroplasty. That's one thing I've noticed. Regarding the tangential trajectories, with the ROSA, that's certainly improved, but compared to other platforms. But if it's really tangential, like more oblique than this, one thing to consider is to take like a matchstick drill and make a crater right where the handheld electric drill is going to go. Put the pilot hole and then subsequently the 4.5 millimeter burr hole. If you make that crater with a little matchstick, essentially every direction is orthogonal with with that handheld striker drill. So that's what we've done in cases where I'm really worried about the obliqueness of the angle. I don't know if that answers your question.
Comment more than question. We do have a clinical trial open here at Case Western in Cleveland with neoadjuvant Pembro and LITT for recurrent GBM. And
yes.
we've got a web address there.
Oh, that's great. Yeah, I'd be curious if they're testing neoadjuvant versus adjuvant, or they just have an arm with LITT or the PD-1 antibody alone. That's interesting, though. No, that's great. I'm aware of that. That's exciting. The one we're doing is in collaboration with University of Florida, Dr. Tran's team in Gainesville.
Yes,
okay.
He replied that we are, but so that's the extent of the question. So I think you can move on.
That's great. No, that's really exciting. So this second case is a 69-year-old right-handed female who underwent surgery for tumor resection in June 2018 for an IDH1 wild-type GBM, MGMT unmethylated, so not a great genetic substrate. And she finished concurrent temozolomide and RT in September 2018, and then temozolomide for 6 cycles. Okay, and this is what her tumor looked like, right, sort of behind the right atrium here, this bubbly tumor here. And then I used a product-occipital approach and craniotomy and removed that tumor. Now, fast forward to April 2020. So this was on the order of about 2 years. So she was doing quite well. And you see this pulvinar lesion that's enhancing on the right. This other speck you see up here is just a huge Verkel-Robin space. So we discussed her in our multidisciplinary tumor board, and what we decided to do is we would enroll her formally in our study, which is actually adjuvant PD-1 antibody and laser. Of course, that starts with a biopsy as well. And for this case, we use intraoperative MRI in Rosa, as I said before, and she also was able to discharge the same day, which was great. And so post-operatively, 2 months post-op, again, she didn't get the immediate post-op MRI because I wanted to get out of there the same day. And this is the lesion here after laser, and again, that very typical eggshell contrast enhancement appearance that you see. And this is 8 months post-op, more, I think it's like a month or two ago, and that's gotten even smaller, and there's no new evidence of recurrence elsewhere, and so she's doing quite well. Are there any questions about that one? It's kind of a similar configuration as the first patient, maybe different genetic subtype and a little more long-term follow-up. All right, case 3. This is a 33-year-old right-handed male without significant past medical history, and he presented with 3 months of headaches. So this prompted an MRI, which showed a large heterogeneously enhancing mass in the right frontal lobe. And 4 weeks prior to meeting me, he underwent resection of the enhancing mass at an outside hospital. And so he came to us for a second opinion. On physical exam, he's intact. He was a pretty young guy. He was like a musician with a young family. And so this was the initial image before that first operation there. You can see it's a sort of wispily enhancing lesion. This sort of this gives you the hint that it's very likely to be IDH1 mutant given his age and the wispiness of that overall enhancement. And this was the immediate first post-operative imaging, and here you can see that the area that they cut out here, and then sort of this remainder of this bulky T2 signal. And he was found to have an IDH1 mutant anaplastic astrocytoma, so WHO gave grade 3 with the typical mutations, IDH1 mutant, ATRX, TP53. And so the question is, what is the next step? And I guess there are a few possibilities here. You could go on forward and treat him with temozolomide and radiation therapy. You could consider also perhaps maybe lasering this bulky disease. It's almost, just given its bulky sort of characteristics, it's almost certain that this is probably a more low-grade component of the same tumor, or you can consider craniotomy. And so after discussing his case, what we decided to do was a redo right frontal craniotomy. I just thought that the configuration of this tumor just wasn't that amenable to laser, number one, and number two, it represented a very large area. It was even larger, superior and inferior to this. I just thought, once you get past that sort of limit of 3+ centimeters in diameter, you just start having a lot more swelling in these kinds of cases. So I thought a craniotomy would be very reasonable. And so we used, we used intraoperative MRI, and we were able to get out essentially the entirety of that T2 bright area. And then he went forward to receive temozolomide and radiation therapy. And so in that case, I mean, we considered laser. In fact, I think we probably should be considering more often for perhaps low-grade components. Is another case I'll show a little later, but not every case, obviously. So I think this is a good sort of different example in which case, in a case where I don't think lasers is the best option. Any questions about that? I guess there are other questions about, I'm sure people are familiar about this literature. There's this growing sense that, I mean, even if it were IDH1 wild type, that the T2 signal is something that you should go after, particularly in young folks. And I guess this is literature both from Ray Sawaya, as well as more recently Mitch Berger. I think the Mitch Berger paper suggests that if you're under 65, that you should go for as much T2 signal abnormality beyond the enhancement as you can. And I think it's some cutoff of 5.4 centimeters or something like that in terms of residual. If you can get under that degree of T2 signal, you can see even in the IDH1 wild type cohort that people would live longer. For older people above 65, it didn't seem to matter as much. So going after the enhancing area seemed reasonable. So this case 4, this is a 54-year-old gentleman, right-handed, with a significant, the history is significant for metastatic melanoma with an unknown primary site, which occurs every once in a while, obviously. And he was found to have 2 brain metastases. So he was first seen at an outside hospital, so he went surgical resection of his larger left parietal brain metastasis in June of 2018. And let me show you what that looks like. And so this was immediately after the first operation. He had his left parietal tumor resected here, and this is just some blood products after. And then he had his other smaller medial occipital lesion, as you can see here. All right, and then he came to us. And so what we ended up doing at that time was stereotactic radiosurgery. We did gamma knife to his right occipital metastasis and hypofractionated radiosurgery to the left parietal cavity. And the reason we did that was that the cavity was still quite big. It hadn't really shrunk down to some small linear area. And so we opted for hypofractionated radiosurgery at that time. And then we continued to follow him, with serial imaging. And so it looked pretty good about 3 months out. This looks, I guess, roughly the same, but it's not any bigger. And then this other lesion in the left parietal area seems to have shrunk down a little to this little wedge. Now, about 2 years later, there were some funny changes on the imaging, and you can see that happened in both lesions here. You can see in the occipital lesion, it's just getting, the area of enhancement is just getting larger, and particularly so for this left parietal region. And at the same time, I think there were discussions going on here. There are a few, MRIs in a row that kind of look like they're creeping bigger and bigger. And so he was put on steroids. And at this point, I think he was having some issues with the steroids. He had some occasional problems with language, for instance. And so what we did at that point was I performed a biopsy, actually, of both lesions, which suggested radiation necrosis rather than tumor progression. But his language continued to worsen, and his requirements for steroids persisted. And again, that had some other effects that he didn't like, including effects on his diabetes and weight gain, things like that. And so we, at that point, his imaging looked like this, which is considerably worse looking than when I was biopsying him. I mean, for most of these lesions, and particularly this parietal lesion. And so what we, and we also looked at advanced imaging at this point, and this parietal lesion right here is right up against this arcuate fasciculus. And so what we decided at that point was to do laser to both lesions. As you know, even if it were, for instance, radiation necrosis, the laser can work very well for that. I thought whether it's a tumor or radiation necrosis, the laser would represent a good therapy. And so we did intraoperative MRI, and in this case, I did stealth vertex. This was before my transition to ROSA robot. And you can see here, we first did the smaller lesion, the occipital lesion, again using a diffusion tip probe here, and covered that with the blue TDT line. And then same time, different trajectory, used the diffusion tip probe for the parietal lesion here. And for the parietal lesion, though, I mean, it's something I may have insinuated about before. For radiation necrosis, you don't have to do the blue TDT line, which is, you know, the thermal dose of 43 degrees for 10 minutes. You can essentially cover the lesion with the yellow line in the radiation necrosis cases, which is not quite a kill dose, and it's the thermal dose equivalent of something like 3 minutes at 43 degrees Celsius. And you know, the reason here being that it's really close to the arcuate fasciculus, which I in fact kiss with the yellow line, but I did not want to reach the blue line. I didn't want to have the blue line hit the arcuate fasciculus. Now, something I would comment on here, I really think whether or not the yellow line or the blue line is injurious to certain tracts or areas really is heavily dependent on how the DTI processing is done at your institution. Because I know there's some literature out there suggesting that if you encounter or touch the corticospinal tracts or other tracts with the yellow TDT line, that will lead to an irreversible neurologic deficit at some institutions. But I could say just because of the thresholding is in different institutions. For our processing, if the yellow TDT line hits the CST, the corticospinal tract, or the arcuate fasciculus, I have not seen irreversible neurologic deficits from that. Typically, I would see either nothing or just temporary deficit. So we performed that. This is what it looked like immediately post-op. In his case, his language is a little worse. I think immediately post-op, I did get a post-operative MRI, and this looks quite well covered. This, I think, I was just shy of covering the anterior end of it again because I didn't want to make his language worse, and then I was getting closer to again arcuate fasciculus. And then fast forwarding about 8 months, both of these lesions have responded quite well to this. This one has really not moved at all, and this one is just dramatically smaller. He's off of steroids at this point, and his language is perfect. So he was very happy with this result. Any questions about that case? I guess one comment I would make is that for metastatic disease, our experience here has been that if you know it's tumor progression, that really anything less than 100% blue TDT coverage of the enhancing lesion is not very effective. And I would go so far as to say that if they're not eloquent areas really close by, I would actually try to go for the white TDT line in the cases for Mets. All right, this is a 45-year-old right-handed gentleman who presented with an episode of unconsciousness that people thought was a seizure. He was put on Keppra, obviously, at that point. And then he was found to have a lesion. We performed subtotal resection at that point. The path was found to be Oligodendroglioma, grade 2, with IDH1 mutation, with 1p and 19q co-deletion. I think this was quite a while ago. I don't think we were doing TERT promoter mutation sequencing at that time. This would almost certainly be TERT promoter mutant as well. And he underwent temozolomide and RT after. And so this was the initial imaging here. It's a temporoinsular tumor, okay, on the right here. And essentially did subtotal resection of the anterior temporal tip. And then after the chemotherapy and that radiation therapy, there was slow and steady growth over time. And at the beginning, I mean, it responded well to the temozolomide and RT, but just you could see the creeping over time. And by the time you get to 2019, the disease is quite bulky, particularly in the anterior medial temporal lobe and also here in the insula. Okay. And so this is what, again, that insular area and lower down, again, anterior and medial temporal lobe, you can see that bulky disease that's just grown over the course of several years. And so we discussed this case in tumor board, and I think a few different possibilities were thrown out, one being maybe just biopsy and maybe re-challenge with temozolomide, another being resection of the insular and the temporal lesions, and then this third option of biopsy plus a 2-stage laser followed by adjuvant temozolomide. And the reason we chose this final this third option is that we have a growing experience now with these low-grade gliomas. In fact, actually it's kind of funny. If you look at the literature on recurrent low-grade gliomas, there's actually not that much guidance in terms of what extent of resection means. I think there's a nice paper from Dr. Silbergeld out in Seattle suggesting that the more you get out the second time, the better is in terms of overall survival. And so just following that concept, I think you can achieve a very similar goal in terms of extent of resection or ablation with the laser. And so we use intraoperative MRI in ROSA here, and here is the first episode, the first trajectory, and that's predominantly insular here. And I used to do these through a parietal approach, and then increasing, I've been moving to a frontal approach. I just feel like you can be clear of the posterior limb corticospinal tract fibers a little better from the front. And then came back for the second trajectory, which is essentially the medial temporal area here, as you can see. And from both of these, I think they were a little larger in terms of the ablation area, so we kept them for a day for each one, but he essentially was normal after each ablation. Well, you can see in the cumulative dose curves here for the blue TDT lines is here. All right, you can see here, insular, and then that's the insular coverage actually. And then during this case also, we're actively looking at the DTI tracts, in this case the corticospinal tract, particularly for the insular pass, because of the reasons I mentioned before. And again, for our institution, the way we threshold it, if the yellow TDT line hits the CST, the tracts of the corticospinal system, then we generally don't see irreversible damage or a deficit. And so these are the final lines. This is the temporal area here. I was showing you the insular area before. And so what we can do is we can arrive at sort of this before and after. So before I was showing you this insular tumor here, this insular bulky lesion, this anterior temporal, medial temporal stuff here. And then 4 months after the second stage, it's really shrunk down to this here in the insula, and then here in the temporal lobe. Now, I've done this with a number of other patients with low-grade glioma as well, 2 stages, and my colleague Dr. Eric Luthard also has done this. I think he actually may have one published case doing this 2-stage LITT for a low-grade glioma. And so I think this is definitely an option, and it's great to add to the arsenal of craniotomy or just chemotherapy RT. And so those are the cases I had. I don't know if anyone has any specific questions about.
Have you ever used LITT for treated meningioma that has radiosurgery related edema?
For meningioma, for radiosurgery mediated treatment effect, I have not used it for that specific case. I think laser is interesting for meningioma. There are some very small series out there. I know when we talk to our buddies in Cleveland, they've also done a number of meningiomas there. I think the time I've been using it in particular is for people with multiple meningiomas and perhaps multiple incisions. And so, you know, to not have to open another incision, maybe perhaps for a person with a grade 2 meningioma who's had 3 already, I think that's an interesting place to use it. I've used the laser for people who have had radiosurgery, not specifically for radiosurgery induced radiation treatment effect, but I think that's a very interesting idea. On the other hand, I have done some meningiomas and it has been not as satisfying. And I think in part that has to do with some of the meningiomas are just sort of more bloody, right, and fluid filled in that sense. And so I don't know if in some of those cases the heating is as effective, quite frankly. So I think it is definitely a case-by-case decision.
Any pre or post-op management pearls, assuming pearls of wisdom, such as steroids or AED?
Yeah, so preoperatively, I think it's just whatever you need symptomatically, generally. What I've been doing for these cases in terms of AEDs is putting them on, unless they had a seizure before, I put them on for Keppra for a week, kind of in the style of trauma guidelines. I feel like we're inducing a trauma to these people. So I've been doing a week and I haven't seen any uptick in my seizures. I used to do 3 months. I used to do craniotomies 3 months. Again, no basis in evidence, and I think we still have no great evidence for the AEDs. But I personally do like a trauma type recommendation of 1 week of Keppra after the laser. And then post-operatively, I guess my thoughts have changed on the management of the Decadron, in particular because some of these people go on trials with anti-PD-1 antibody, and the highest you can really go with those agents is really 2 milligrams BID. And so I think what we did before is we used to really do probably about Decadron for about 2 weeks or so, and with the larger lesions even 3 weeks, you know, something, you know, 4 Q6, 4 TID down to 0 over the course of 2-3 weeks. But I've been more aggressive about it, particularly because of this pembrolizumab trial we have. You really need to get them down to 2 BID. In fact, if I can get away with it, I won't have them go higher than 2 BID if I know they're going to go on that LITT with PD-1 antibody trial.
For symptomatic patients with brain met treated with LITT, how long after LITT would symptoms usually persist?
Yeah, that's an interesting question. I generally think the longest I've treated in that situation is about 3 weeks. I would say 3 weeks is generally adequate, but I'd say on average it's more on the order of about 2 weeks. But again, it really depends on the diameter of the thing, right? If you're pushing 3 or more than 3 centimeters in diameter for a lesion, I mean, that's when sometimes you need about 3 weeks or so for the steroids.
Okay, great. Here's another one. For the stage 2 LITT procedures, how far apart are the stages planned?
Yeah, we've typically done about 2 or 3 months in between. I would say that's, yeah, I plan for about 2 months. That seems to be, I don't know, I feel like, you know, by 4 to 8 weeks the anesthesia is washed out of your system, and then some of the lack of interpretability of the MRI because of the, you know, the acute surgical changes starts to disappear on the MRI. So we generally wait about 2 months.
Okay, great. Any timing recommendations between multiple trajectory treatments?
I guess, I mean, besides the 2-month interval between the two trajectories, is that what you mean? You know, I have been asked this question recently. I don't actually know the answer to this, whether doing laser in the same area twice in the course of a few months or within a month or two increases the degree of edema. My sense is generally not, but that's something that's come up recently. I personally think it's more a function of just the physical diameter of what you're treating. Again, that sort of upper limit of 3.5 centimeters.
For mass-like flare in LGG, is there a difference in the ideal diameter/volume for LITT? Presumably, this is a denser tumor than a necrotic GBM.
Yeah, that's interesting. I mean, a few comments on that. You know, I think the low-grade gliomas actually heat up quite efficiently. There'll be cases of GBM, and again, I think it's like those meningiomas that are really quite bloody, where it's very hard to heat in certain directions in GBM. But for low grades, the heating seems to be overall pretty symmetrical and proceeds at a reasonable pace. About treating the flare beyond it, I guess I've generally tried to get as much as I can. There's this sort of extreme case I did of an IDH1 mutant grade 4 astrocytoma that had some low-grade elements in a young woman, like 30 years old. It was like medial frontoparietal, so left medial frontoparietal. I mean, basically looks impossible by craniotomy. But I put the laser in the middle of it. It was like essentially a small Nerf football, and I went beyond the enhancing area also to the T2 bright area. I guess the question is if you get into that sort of finger-like infiltrative, well, I only want to call it that, that's finger-like T2 area that you don't know if it's edema versus really tumor bulk. I don't have a good suggestion for that. Me personally, if it's in a safe zone, I'll actually even go after that. I think just in terms of what we use the laser most frequently for, I would say right now we use it most frequently for recurrent gliomas, whether they're high grade or low grade. I think it's a great technology for those cases. And again, the exciting thing, and as mentioned by the person from Case Western as well, is that you can really envision new clinical trials along with laser, and I think that's really exciting. And you know, I guess at the end of the day, another way to look at it is that if it gives you the same thing as a craniotomy, you know, and yet it gets you back on your feet more quickly, I think that's great. I'm not pretending to say that this is some magic bullet. I think it remains to be seen what exactly we are doing to the microenvironment that is different from craniotomy and resection, if at all. I think that really needs to be known. But for now, in my mind, you achieve a very similar goal as resection. So, you know, if you can get them back on your feet, I have this one patient I have who is just so resilient. Again, I recently treated him for recurrent glioma, and he left the same day, discharged. The guy was working like a week later. That definitely wouldn't happen with a craniotomy. So I like this technology for the recurrent gliomas. And then the refractory Mets are another great group of patients to treat with this. The radiation necrosis really does respond great to that yellow TDT line coverage. And again, the caveat with tumor progression, however, is that I think you really need to cover or overcover the tumor with the blue TDT line.
Do you find repeat recurrence of gliomas is slowed with LITT versus redo craniotomy for re-resection?
So the LITT gives you better control, local control versus craniotomy. Huh. I don't know if that's true. I mean, the other caveat here is that, you know, we're often doing, I mean, we had 2 trials, one that's finished. We have a doxorubicin plus laser trial with the idea there being that doxorubicin, which is never getting in the brain, can be facilitated to enter brain tumors and brain areas by the laser. That's finished. And you know, with this adjuvant pembrolizumab with LITT trial, I guess, huh? Yeah, I mean, I don't know if that answers the question. It's hard to know because you're doing something else with the LITT. So I don't know if I can make the strict comparison between LITT only and craniotomy only. I guess that's what I'm sort of that's what I'm saying. You know, I guess all comers in our series of recurrent GBMs, if I think about it, our overall survival is on the order of I would say on the order of something between 11.5 to 12 months. And so that's slightly better than industry standard of CCNU and Avastin, right, of about 9 months. But again, it's kind of a mix of different patients on these different trials, like I said, the doxorubicin and the PD-1, et cetera.
I want to thank Dr. Kim for the terrific presentation, and of course, thank you to everybody for carving out time from your busy schedule to attend.